Welcome, everyone. I would like to thank Carolyn, Baron-Myak, and Andrea, DTA, for presenting for us today. Again, we will be encouraging questions and feedback from the audience, and you can do this by two ways. You can press *1 on your phone, and the operator will introduce you that there's a question from the audience, and we will take that as soon as we can. Or if you prefer, you can use the Q&A feature located at the top of your screen. You simply click on that feature, and you can type in your question, and we get a signal that there's a question in queue, and we can take that at the first opportunity possible. With that, I will go ahead and turn things over to you, Caroline. Caroline, it's all yours.
Thank you very much. Hello, everyone. Our topic of discussion today is informed consent and CTN protocols. As Liz mentioned, my name is Baron-Myak, and I've worked as part of the NIDA CTN Appalachian Tri-State Node as a research coordinator for CTN 32 and currently Project Aware, as well as a backup RA and a backup QA for 46 and 47. Today, we're going to cover a number of objectives that include review of the principles behind the informed consent. We'll look at a brief history timeline that created the informed consent system as a system of protection today, the document versus the process, the informed consent language, the informed consent development, review, and approval process, as well as opportunities for improving the consent documentation and process. That's the area we're going to probably pay most attention to, looking at areas of improvement, ways to minimize errors. So we'll go on to the review of the principles, and that's slide 4. We'll look at a quick timeline, starting with the Nuremberg Code of 1947. That code was developed in response to the Nuremberg trials of Nazi doctors who performed unethical experimentations during World War II. It led to the voluntary consent of human subjects as being absolutely essential. They have to be able to consent, they have to be free from coercion, and they have to understand the risks versus the benefits. I'd like to mention in 1964 there was the Declaration of the Helsinki, where the World Medical Association adopted 12 principles to guide physicians on ethical considerations. In 1974 is another marker where U.S. Congress created a National Commission for Protection of Subjects of Biomedical or Behavioral Research, and that led to that Belmont report in 1979. Where they focused on the principles and guidelines for the protection of these human subjects. One, in regards to respect, recognizing participants with diminished autonomy, the young and the old, beneficence, protection from harm, maximize their benefits, minimize the risks, and as justice is the third, fair distribution of what we're asking of them. In response to the Belmont report, the Health and Human Services and FDA revised their regulations on research studies that involve people. 1991, the federal policy to ensure a uniform system of protection in all federal agencies and departments that conduct research. And now we're going to move to a polling question.
Okay.
We have a few polling questions throughout. Liz, are you going to read?
Sure will. Myth or fact, the most important part of the process is signing the informed consent document. Is this a myth or is this a fact? The polls are now open. You can put in your responses. Okay, Carrie, I'm going to go ahead and show results.
Sure.
Fantastic. It looks like about 86%.
Right, that say that this is a myth, and that's true. It is a myth. The most important part of the process is having those things we identified as being the most important things, that they understand what they're signing. It's not just the actual signing of the document.
Okay, we have one more myth or fact question, which we thought was kind of a fun way to get people started in today's presentation. Myth or fact, my doctor knows best. He or she can tell me whether or not I should consent to participate. Myth or fact? The poll's now open. Okay, I'm going to go ahead and show the results and ask Carrie if you can go ahead and review the findings.
Very wonderful. It looks like everybody was on board with this one. You know, it is the participant's decision. They have to make an informed decision for themselves regarding whether or not they should participate.
All right, I'll go back to the presentation. There you go, Carrie.
All right, we're looking at slide 5, and this is a cartoon equation, and it sums up beautifully what we're really trying to achieve. You have an addition of trust, which means, you want to build trust and develop rapport with the participant. If you add an inform and ensure understanding by good communication, revealing, listening, and understanding, it's going to equal ongoing assurance to show respect for people, for persons. And I think this breeds success for retention, follow-up, their whole participation in the study. And I really like this cartoon equation. I think it kind of sums up beautifully what we're trying to do in the informed consent process. We're going to look at slide 7, which is the informed consent document. Informed consent really has 2 essential parts, the document, which we're going to discuss now, and the process. The document itself is the stepping stone for the process. What it does is it's going to do a number of things. It will ensure things and provide a mechanism to things. What it ensures is that you're providing initial ongoing respect for human participants, research participants, and it provides informed and voluntary study participation. The document itself is, like it says in that little cartoon, proof is in the pudding, but our document is the pudding. It's the essential meat of what we're doing. It provides a mechanism to review the study information, the purpose, the treatment procedures and schedules, the sites and PIs involved, including their phone numbers, risks and benefits, other options for care. It's also a document that shows us agreement from the participant when they do sign. So the document is very important. It is the stepping stone to the process. We look at slide 8, we'll go over the process piece, which is the relationship building. The process does not stop, as most people think, sometimes when the participant signs a study consent. It's an interactive process. We, as a CTN, we try to provide information throughout the study. We want their support. We provide relevant information to participants. We want to promote full understanding. We want to assure participation is voluntary. And, the process is extremely important, again, to the success of the study, and that little cartoon kind of reflects it all. The informed consent outcome, this is what we want to achieve. We want the participant to have adequate knowledge and understanding of that research. We want to make sure that as staff we answered all questions, assess and assure an understanding that they have, and the process, the project representative signature. Once we have a clear belief that the patient is understanding what's going on, they're ready to sign, and that's the last piece, is really what we want, the outcome. We're going to move to another polling question.
Okay, once again, myth or fact. Medical personnel are busy, so I can't really expect them to keep me informed as the trial progresses or to listen to my questions. Is this a myth or a fact? Now, these questions we gathered, there's a great website called NCI website that has a guidance for informed consent, and they had some great myth or fact questions. We thought we'd put them in here for kicks and giggles, I suppose. Carrie, you want to go ahead and show the results?
Sure. It looks like everybody realizes that this is a myth, that, we really want them to have the understanding that we'll update them throughout, that they're free to ask questions throughout the study. And, that's what their expectation should be, is that we will keep them informed. And now I think we're moving on to Andrea.
Thank you, Caroline. Hi, everybody. Okay, before I discuss a bit of detail about the structural elements of the informed consent document, I wanted to highlight the last 3 bullets in this slide that talks about the fact that we need to write the consent in the 6th to 8th grade at the 6th to 8th grade reading level, and that we need to avoid technical jargon, and I would add abbreviations and acronyms, and that the document should be written in a clear font with correct grammar and punctuation. So the reason for these requirements are simply to improve the readability of the document, and essentially the document must be understandable to the average reader. So now I'm going to get into a little bit more discussion about the elements. So there are 8 basic or essential elements required for the consent document. And so having these 8 elements in your consent pretty much makes the document legally effective. And it's a means of ensuring that the document explains all of the information that any reasonable person would want to know about before deciding to participate in a study. So I would just like to highlight 4 of these required elements. Not that the 8 are not important. They're all necessary and important, but for the purpose of this presentation, I'm going to do 4. So the first element states that we need a statement that states that the study involves research. And what this is pointing to pretty much is that we need to have a statement that talks about any experimental procedure. Element number 2, description of foreseeable risk and discomfort. So pretty much we need to have a statement that reasonably describing that risk can be reasonably or should be anticipated and what those risks are. Element number 5, statement describing the extent to which confidentiality will be maintained. So this element is pointing to the fact that we need to have a statement saying who has access to the data and who needs to know about our consent information. So, for example, we may have a statement that says, the investigator or the FDA may inspect your records. Element number 7, explain an explanation of who to contact for questions. So this element is pointing to the fact that we need to have a statement saying, who do I call for questions? The participants need to know who to call with questions, complaints, or concerns. So now there are 6 additional elements that are required as appropriate, depending on the study and the study population. So these additional elements are additional safeguards that are put in place for vulnerable populations. And in the CTN and for the purposes of our research, substance abuse, we tend to include a lot of these additional 6 elements so that we can provide additional protections to our participants. Again, I would just like to highlight 2 of those 6 elements. Element number 3, any additional cost to the subject that may result from participation. So a lot of times this is pointing to the fact of research-related injuries or any injury that may be experienced by participants in the conduct of the study. So there needs to be a statement saying whether or not there will be additional compensation for being involved in the study. Element number 5, a statement that significant new findings which may affect the participant's willingness to continue will be provided to the participant. So this element is pointing to the fact that there needs to be a statement indicating how new findings will be communicated to the participant during the course of the study. Okay, so I'm moving on to the next slide. So we're going to discuss the informed consent development review and approval process in the CTN. So as we know, the protocol team develops the informed consent document. And so once this document is developed by either the PI, the lead node, the document is sent to EMMES or the CCC to the protocol specialist for that study and to the regulatory specialist. So they review the document, again, to ensure the readability is good and to ensure that all of the required elements are there. And then the document goes back to the lead node, and they will disseminate the document to the IRB, to the site, who will in turn send the documents to their individual IRBs as appropriate. So here we are at the point of the IRB review. So this is the final review and approval for the informed consent document. And I just want to talk a little bit about the IRB. So in my previous experience where I conducted review of the conduct of IRBs, it was very evident that IRBs spend a lot of time reviewing the informed consent document. And it was not because the document was more important than minimizing risk to participants, but mainly because the informed consents submitted to the IRBs were often of such poor quality that it was necessary for the IRBs to spend a lot of time reviewing the document to make sure that it's legally correct and that participants will understand what they're signing on to. So I would also add that in the CTN, we really don't have trouble with this part. We pretty much have mastered how to put together a good informed consent document. Where we tend to struggle, I have found, is with other parts of the, showing, as Caroline said, the pudding, making sure that the pudding is correct, making sure that we sign properly, that we avoid simple errors as we, administer this informed consent document. So once the IRB approves the document, then, they send in a letter with an approval date, an expiration period, and a period for continuing, the date when the continuing review is expected to happen. Next slide. So in this slide, number 16, we're going to have another polling question.
Want to cover the polling question now?
Yeah. Okay. Okay, so here we go. I'm going to talk a little bit about the monitor. So when the monitors come to your site, either the local QA monitor or the EMMES monitor, we go through a series of steps to assess whether or not the participant's consent was informed and that all, steps were correctly taken. So it may vary how the monitors review this, but pretty much we cover the same information. So we looked at the version of the consent, and we make sure the participant signed the correct version at the time they entered the study. We also make sure that the consent was signed prior to the participant performing any study assessments. We look at the pages. We want to make sure that all of the pages, whether it's 1 through 12, we make sure that all the pages are there, that the participant signed in the lines and sections provided, and that it's dated with the correct date. We compare the participant's name with the master enrollment log, to make sure that the participant exists and this is a real person, and that other study records exist for the person that signed this consent document. We also review who administered the consent. We look at the staff signature and delegation log, and we compare the signatures to make sure that the person who gave the consent was authorized to do so and that they received all the appropriate training. At this time, we'll have a polling question before we go into the next segment.
So what do you think? What percentage of protocol violations occur from informed consent issues? Do you think 5%, 10%, 15, 20, 25, or more than 30%? The polls are now open. Wow, so we have, I'm going to go ahead and show the results. We have 41% of you believe that the percentage of protocol violations related to informed consent issues is over 30%. 29% think that it is about 25% of the issues are informed consent related. So I'm going to ask one more polling question, and then Andrea's got some interesting statistics to show about what we found here. So the next polling question, what do you think? Informed consent-related protocol violations occur occasionally across CTN files, true or false? So we'll go ahead and show those results. 65% say that it's false, that it's not occasionally, and 42% say that, yes, indeed, it is just an occasion that PVs happen and related to informed consent across CTN trials. So let's go ahead and go to the presentation, and we can share what we found.
Okay, so those were very interesting responses. So here we have a pie chart of the data that we actually found in Advantage EDC. For all the protocol violations entered, 25% of those violations were related to informed consent issues, and a lot of it were, consistent issues, minor errors with regard to the pudding, the documentation, the errors in signatures, or pretty much making not consistent with what's required by regulations. So at this point, Caroline will talk about how we may improve these numbers.
Okay, Caroline, you want to go ahead and go over some of the improvement opportunities?
Sure. And looking at this, there is a process for methodology that's listed nicely on the next slide. It's also on a flow sheet following this slide on number 20, where it kind of, it kind of puts it in a nice flow for us to look at. It starts with the list of critical to quality requirements, what our basic requirements are in regards to doing the informed consent. And that would be such things as, providing the participant with the initial and ongoing information, assessing their comprehension, the documentation that's necessary. So after you list that critical to quality requirements, you want to look at identify the improvement opportunities. How can we make this process better? Then you link deficiencies to the source, look at past issues and difficulties. You try to strategize to address the deficiencies. At every site level, we want to see what could be done. You want to implement and test it, either by mock trials of it. There are various ways to implement and test it. And you want to develop a standard operating procedure. You want your site-specific SOPs to be the guide for the study staff. And, what I like to think about in this process is to use this methodology even before we have a deviation or a violation. It can be used when you start up a study, and I think it's very essential for your site team to think about what's worked in the past, what hasn't worked in the past, and incorporate that right then and there in their site-specific, SOPs. And that leads us to the requirements that I mentioned earlier when we list the critical to quality requirements. The ones we have listed on the slide 21 is, provide that participant with the initial and ongoing information needed to make an informed decision. Again, we want to assess the participant's comprehension, and we can do that either open-ended or through a quiz. Document the participant's voluntary agreement for the study participation. And I think, these are the things that a consent must show and have. If we look at the verifying part of the informed consent quality, we want to make sure that the document, like we said, is our evidence. We want to make sure that documentation shows what we have done with the participant, that the participant has a clear understanding and that it's a voluntary agreement, and that the document was signed correctly, dated correctly, initialed, and the quiz was done, properly. That's all part of the verifying that the informed consent's quality is there. These are the minimum requirements. That leads us to one of our key points, the critical to quality. That's the actual work and the verification of the work. We want to, if anything we get out of this talk today, we want to focus on these three zones to pay attention to, the facilitation, the process, and the verification. Those are some of the key elements. The facilitation, what could we do on the onset of a study to help assure that, we're going to make it the best likelihood, not to miss things, to make it easier for ourselves as a site. It could be as completing pre-packets for your study startup so that you have the latest version of the consent right there on hand. Those are some, that's one way. The process is to a step-by-step process. What is the process we're using? And the verification of the quality achieved. How are we checking, or how are we verifying what we're doing? And, I think it's all about the approach, the doing, and the checking, and that's really what we want to focus on. In the next slide, which is 24, we're going to look at some real common documentation errors. These are the ones that have been identified as, part of the protocol violations that have come up in the past. And we're going to try to categorize them in the setup and the performance and verification. So we have the actions to facilitate, and we have the process and the review for quality. And these are the most common ones, these 12. So I think we're going to just try to go through them, and I'm going to see if Andrea wouldn't mind if she could kind of give me her opinion as what she feels this falls into.
Carolyn, I'll be happy to do that.
All right, we're going to look at the first one, expired, obsolete, or retired consent version used and signed by the participant. Where do you think that falls?
I would agree that it falls in the setup, actions to facilitate quality.
Yeah, I agree. At least on my end, as part of a site, I feel that, that's where the pre-packets or that's where the reviewing of things come in handy. How about the incomplete consent forms, missing pages?
Again, the setup, actions to facilitate quality. And now that I'm thinking about it, it could also be a process issue where someone could be checking that all the pages are there in the packet.
Right, because it could be happening when you make a copy of the consent for the participant or something like that. Also, faded copies, sections of the consent are unreadable.
The setup, I would agree with that.
How about the signature of staff obtaining consent is missing, undated or dated incorrectly?
Performing the quality review.
Right. So making sure that the review process, is fine-tuned. Consent is signed and dated by required study staff days after the participant signs.
I would agree that is the process, the performing.
Okay. And the participant did not initial all required sections within the consent form.
I would also agree with the process.
Me too. The participant signs the wrong date.
The setup.
Right, and I can see where this also could be the process. This is where props might be helpful, like a calendar, on the desk where the participant is, reviewing the consent with you, so they can, that could be definitely part of the setup. But also it's part of the process because you're actually signing with the participant on that same consent, or the PI is. So it's important that that process, is also a piece that you're checking to see about the date, that you're all acclimated to that. Signature and date errors are crossed out and not initialed and dated.
I would agree, Caroline. It is the process.
So do I. And the participant corrects a quiz question and does not initial and date the correction where the error occurred.
The setup.
Okay. Participant did not receive a copy of the signed consent form.
The quality process.
The process, okay. And no progress note written documenting that the consent process was conducted and that the consent form was signed prior to conducting any study-related procedures.
Well, the process, I would agree with that.
Right. And when we look at the process and the review for quality, it's really twofold. Whenever you have a process problem, you know, that's also going to fall in the review category because everything should be checked. You know, it's important to have that check and balance. All right, and I think we're going to move on to Andrea to review slide 25.
So again, we have additional data that was found here at the CTN, where the protocol specialist went through the informed consent violations and found that the deficiency sources were 56% attributed to the process issues and 44% to actions required to facilitate quality.
So I think that leads us to strategies to address these deficiencies. And, you know, we can go on, and I'd love some cite, you know, opinions on what they've done or what they've noticed in the past and how they've corrected things. I think it's going to be a learning experience for all because as all sites, we want to, you know, we wanted to do the best job we can. And, you know, it's sometimes when you're so very close to starting a study and running the study, it becomes second nature, and it's so important to have these things identified early on in an SOP. But some of the strategies that we came up with, you know, just here in our webinar, just a few. One was that we have a QA process in place before the participant leaves the site. You know, in our site, we try to have that happen with another study member who's, you know, is aware of it. So anytime we have a participant consent, we have them, you know, second look at that consent. And we try at our site not to make process shortcuts because we find that when we're under a lot of stress or when the situation is busy, sometimes these shortcuts lead to bigger problems because you're moving too fast. And you need to allow time for each aspect, and especially with the informed consent when you could have one or two consents to do. With Project Aware, we had two consents, one for the main study and one for HIV testing. So the participant was looking at, you know, two pretty lengthy consents to review. All right, moving on to perceptions of value.
Okay, thank you, Caroline. So here, we wanted to point to the whole idea value and what we perceive as valuable. So in the accounting world, the financial world, we always, you know, consider that the importance of money and the importance of making sure financial transactions are correct. And so by the same token, we want to, in research, we want to make sure that we apply the same checks and balances, and we allot time to making sure that these ethical transactions are also correct as we conduct our research.
And looking at quality verification, what comes to mind most is double checking. We believe it's a two staff member job. One is a staff member completing the informed consent, and then having another qualified person, staff member, you know, assigned to reviewing it. Other thoughts, using a review template for quizzes so that it gives less thought. You can actually check it with the participant. You can put the template over top the quiz answers and see where they've missed, if they've missed, and the corrections can happen, you know, right there. And I think the double check method, you know, can address a lot of those documentation errors that we're finding, but it really has to be site specific. Everybody has to come up with their own ways that works for them. But you know, it's a process that we all need to think about when we see statistics and when we see where the errors are happening. Last but not least, I just wanted to touch base real quick on time constrictions. we mentioned that time constrictions sometimes constricts quality, and I think that other considerations that come into play is that we're often, when we start a study, given timelines for certain procedures, and by the lead team or by the PIs, where they think it takes this amount of time to address this interview. And I think that adds to a lot of pressure, because sometimes a participant needs more time than's allotted, and things can't always be done as quickly. And I think that is a factor that leads to sometimes shortcuts or those kind of events that happen. And I just wanted to throw it out there, because I know in our site at times when it gets stressful, sometimes time constrictions do play a part in how we do our work. So maybe other sites will have other ideas or input.
Okay, do we have any questions or comments at this time? I see that we have one question that's in the queue here. And this question asks, how do we keep the level of language of a consent form at a level that meets the participant's reading level? Andrea, did you want to add anything to that or address that?
Okay, so with regard to the reading level, a lot of times IRBs do test the reading level language in the document. So this is prior to IRB approval. They have programs they use. Sometimes they give the consent to individuals to read to test whether or not it meets that criteria. So there are ways, there are tools and programs that are used to test that. And so once it's been approved, once the document's been approved, then once the participant reads and does the quiz, then sometimes it's a good indication. Sometimes the participants will tell you whether or not things were clear to them. But to answer the question directly, it starts prior to the IRB approval.
Great. Do we have any questions from the audience at this time? If you would like to propose a question, press *1 on your phone, and the operator will open up your line to interact with the presenters.
Standing by for audio questions.
Okay, I think that means that we covered everything pretty well. I think the key to the presentation probably is in identifying that there are three various areas of where quality can be improved, and the activity of going through frequent errors and identifying where could the source of that error be, and just working with the people who are doing the consent on a daily basis to strategize to address those problems. This speaks to, in business practice, the Kaysian method, which is a method of continual improvement. And this is just a mechanism to help you guys address errors or deficiencies and ways in which your process can help support you and the quality of your informed consents. I want to take an opportunity to thank Carolyn Baron-Myak and Andrea DTA for presenting for us today. If you did miss today's presentation, we will be posting the recorded presentation on LiveLink as well as on the CTN Dissemination Library. If indeed you would like a copy of this presentation, we will also send it to your site if you send a request to ctntraining@emmes.com or to ebuttree@emmes.com or to theightman@emmes.com. Our next webinar coming up will be on December 7th, where we will take a look at the Manual of Procedure Development. Again, thanks very much for joining us today. If you have any follow-up questions, you can feel free to email us, or you can email me at ebuttree@emmes.com, and we will provide some follow-up support or response to your request. Thank you, everybody. Have a great afternoon.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.